Hey, hello everyone. I'm going to talk about dysrhythmias, which is like one of my favorite topics to talk about. So I'm going to just teach you some very basic things you need to know about dysrhythmias. We don't get too deep. I do want to tell you that recently LPNs are being asked to come back into the hospital. And I have seen some PNs working in telemetry and working on step down. So it is important that you do have a basic understanding, okay? So we're going to just start with a little physiology. We're not getting deep because it's way too boring, okay? I just need you to know a few things, okay? The SA node is in the right atrium. That's not what is important. What's important is that the SA node is the pacemaker of the heart. So that means it has an automatic rhythm, right? 60 to 100 beats a minute. It's shooting off an impulse, okay? And that should be easy for you to remember because that's the normal pulse rate, right? Now, let's say the SA node is sick. It's having a bad day. So it's not going to go to work today. So then the AV node can take over, okay? So this is called the gatekeeper. It lets all the impulses through, and that will fire at a rate of 40 to 60 beats per minute. Okay, now the impulse goes from the SA node to the AV node, down the bundle of His to the right bundle and the left bundle, and to the Purkinje fibers and the ventricles. So let's say the pacemaker and the gatekeeper are both going to sleep. They're not going to work today. The Purkinje fibers and the ventricles can initiate an impulse at 20 to 40 beats per minute. Now, that's not like going to make or break you. I'm just like trying to explain some basic physiology to you, okay? So you don't need to like memorize that, okay? Now, we are going to talk about waves a little bit, okay, in intervals, because that's kind of what we look at, but we're not going to get that deep, okay? So on this little diagram I have here, you see the P wave. The P wave represents atrial contraction. So it represents when the atria contract. So when the atria contract, they push blood into the ventricles, okay? That's what that's for. The PR interval is from the beginning of the P wave to right before the QRS, okay? Maybe about there, okay? And this is the impulse from the atria, atrial depolarization, and it's going through the bundle of His down the Purkinje fibers right before the Purkinje fibers go off. That's that impulse right there, okay? This is the Q wave right here, and we'll talk more about that with MI, okay? And this is the QRS complex. So QRS, okay? It looks like an upside down V for ventricle. This represents ventricular contraction, the QRS complex, okay? Then you have the ST segment, which is right here, and it should be flat, okay? If you look right here, it's on the same line with this. So this is called isoelectric. Don't worry about the T wave. Don't worry about the U wave, okay? We're not even going to talk about that. All right. Now, the ECG is presented on graph paper and that, so we can measure things, okay? So it's measured horizontally. Time is measured horizontally, sorry. So one little box represents 0.04 seconds. So this is a little box. And this right here is a big box. And so this would be 0.2 seconds. Okay? So the little box is 0.04. There's 5 little boxes in a big box. So one big box is 0.2 seconds. Okay. So normal conduction, your PR interval should be 0.12 to 2 seconds. And you don't even need to know fast or slow because we're not getting that deep. QRS is going to be less than 12 seconds. Means it's going to be skinny. It's going to be narrow. Narrow is normal. So we like that. Okay? And you're not even going to be asked to measure intervals. You're going to eyeball it. I'm going to show you how. Okay, so there are some steps that you do need to know to measuring a rhythm strip, okay? The first thing we're going to do is determine the heart rate, then the rhythm, Then we're going to analyze the P waves, measure the PR interval, measure the QRS complexes, and examine the ST segment. Okay, now the rate. Now, when you get an ECG, a strip, you'll notice they have these little tick marks on the top. Okay? Right here and right here. Okay? Whoops. Right here. Okay? So from here to here is 3 seconds. And from here to here is 3 seconds. Whoops. So this whole thing, from this tick mark all the way to this tick mark, is 6 seconds. So this is a 6-second strip. Okay, 6 seconds. All you do, if the rhythm is regular, this is a nice regular rhythm, is count the number of QRSs and multiply by 10. So this heart rate is 90. Okay, because there's 9. Let me see, is this one inside? Okay, so you wouldn't count this one because it's outside. Okay, so you only count the ones inside the 6-second strip. The rhythm you can do with an index card. You just put little marks where the P waves are and just go, see, they start here and then they move to these two and it should all map out. Okay, now we're going to look at the P waves. Now, here's where it gets important, okay? You want to know if they're upright, rounded, and if there's one for each QRS before the QRS, okay? Do they all look the same? Do you see fib waves? We're going to talk about AFib in a little bit, so that's important. PR interval, you just want to know if it's present and they're all the same size, okay? The QRS complex, we want it less than 0.12 seconds, okay? We want to know, remember, it represents ventricular depolarization, which means ventricular contraction, okay? You want to know if they're present and if they all look alike. And you want to see one QRS following each P wave. Next, we're going to look at the ST segment, okay? It should be isoelectric, meaning flat. If it's not, okay, it means something. If it's not flat. If it's high, this is a high ST segment, kind of looks like a fire chief hat, right? Here's the like thing on front of their hat, and here's the high thing, all right? They can look like tombstones as well, okay? That's the way they're described. Remember this. If the ST segment is high, it stands for DI-MI, okay? This means the muscle is dying. So this usually happens when somebody's having an MI or heart attack, right? Depression, okay? Remember this. Low means slow blood flow. Low, slow blood flow. So that's high DI-MI, and it's low, slow blood flow, okay? So this means ischemia, right? The blood flow is diminished. Okay, now let's talk about dysrhythmia and ectopy. So ectopy means somebody's having an abnormal rhythm, okay? Something is oddly placed. So something is not right with their rhythm. And I'm going to teach you a mnemonic, okay? So you can understand what causes dysrhythmias, okay? The mnemonic is stop eating dog snacks, eat healthy. So these are the main culprits of dysrhythmias, okay? Stress. Too much alcohol, either, chronic alcoholism or, in the moment, being drunk, so to speak. Digoxin. Digoxin is a drug we often give to treat dysrhythmias, but it can also cause dysrhythmias, okay? Stimulants like caffeine, tobacco, nicotine. Electrolyte disorders. The two most common electrolyte disorders are going to be your low potassium and your low magnesium, okay? Hyperthyroidism or hypoxia, okay? So these are the most common reasons, or hypoxemia, right? Most common reasons people have dysrhythmias. older adults. The reason they're more common in older adults is because they're getting older, right? So everything slows down. They get decreased number of SA cells. They have fibrosis of their conduction system, increased number of fat cells around the SA node, calcification of the SA node, less responsive conductive system, meaning they're a little bit slower than they used to be, right? And a decreased strength of contraction. I talked about that in one of the former lectures, okay? As you age, the muscles in your body get weaker, okay? If you don't keep up, even your heart is a muscle, okay? So as you age, they're going to have decreased strength of contraction. That could lead to dysrhythmias. It can also lead to heart failure. All right, the treatment. You discover your patient has a dysrhythmia. There's one of four things we can do. We're going to assess, and if the patient is fine, we're going to continue to monitor. But in some cases, we're also going to investigate, and we'll talk about that. We're going to eliminate the source, like tell your patient to stop eating the dog snacks, right? Don't drink those big monster drinks and expect your heart not to have PVCs, okay? So they have to eliminate sources. Medications, we can treat dysrhythmias with medications, and if medications don't work, we can treat it with electricity, okay? To jumpstart the heart, so to speak. Okay, now you have to know what normal is so you can see what abnormal looks like, okay? Now, you do need to memorize the characteristics of normal sinus rhythm, okay? So the heart rate is going to be 60 to 100 beats per minute, which is the normal pulse. So that should be easy for you to remember. It should be regular. That should be easy to remember, right? The P waves are going to be upright, consistent, and there'll be one before each QRS. The PR interval is going to be 0.12 to 0.2 seconds, okay? And I wouldn't worry so much about that because for you, like I'm going to show you, here's the beginning of, oops, that's not good. Let me draw it this way. Here's the beginning of one. And here's another one. I can already see this is smaller than 0.2, okay, seconds, because one big box is 0.2 seconds. Don't even worry about that, okay? You're looking for a regular rhythm that is 60 to 100 beats per minute. You're looking for a narrow QRS, okay, so that one's narrow, it's skinny. You're looking for a flat ST segment, and you're going to assess and continue to monitor. Okay, sinus brady is the same as normal sinus rhythm, but the heart rate is less than 60. So you see how easy this is? Just less than 60. All right, here's the cause of sinus brady. Now, don't memorize this. I'm going to show you a few things you need to know. Okay, so it's just acute pneumonic. If you become a critical care nurse, you can come and retrieve this and learn all you want. But I'm just going to show you a couple of things, okay? You already know beta blockers. We hold for a heart rate less than 50. A lot of times we give a beta blocker to slow the heart rate, okay? So it could cause a slow heart rate. Calcium channel blockers, very same thing, can cause a slow heart rate. Potassium, you already learned about this. It can cause a low heart rate. Digoxin, right? It can cause a slow heart rate. That's why we take an apical pulse before we give digoxin, okay? And we hold for less than 60. And remember where you do your apical, right? And athletes, okay? So that's another reason. All right. Now, you have a patient, sinus brady, okay? First thing, every dysrhythmia, you're going to assess. Check the LOC and vital signs. The reason is, if the heart rate gets really slow and the patient's heart is not perfusing, meaning it's not beating fast enough to perfuse their brain, right? That's the quickest way to tell that they're not perfusing. They're going to get confused, okay? Their vital signs will have like a low blood pressure, okay? If the blood pressure is not adequate, we worry they're going to go into heart failure. But anyways, if they're unstable, they're confused, they have a low blood pressure, you're going to call a rapid. Stay with your patient. Prepare to administer atropine. And the way I remember it, that atropine raises the heart rate is because on the end of atropine is pine, and a pine tree grows tall, so it grows big, so it makes it bigger. So anyways, that's how I remember that. So if their patient is stable, when you do it, investigate. Look and see if your patient's on one of those medications we talked about. Ask them if they're an athlete. And the drug of choice for bradycardia is atropine. And if atropine doesn't work, they're going to get a pacemaker. I'm not going to go into a lot of detail about pacemakers. The only thing, there's some nursing implications, like you need to teach your patient how to take their pulse every day. They need to carry like a card with them. They cannot go through airport security if they have a pacemaker or what's called an AICD, automatic cardioverter defibrillator, and we'll talk about that when we talk about the heart lecture or a little bit later, okay? And they can't have MRIs as well. They are now making MRIs that can take people with pacemakers, but for your NCLEX, no MRIs, okay? Sinus tach has all the same criteria, except the heart rate is greater than 100. So all the same criteria as normal sinus rhythm, okay? All right, now these are the things that cause tachycardia. Do not memorize this, okay? I'm going to point out a few things to you. Now, sinus tachycardia is a message that the body is sending out that it needs more oxygen, okay? So it's a stress response. Our bodies are amazing. They feel like we have low perfusion or we need more oxygen somewhere. And so the first thing that happens is the heart starts beating faster, okay? Now you already know medications like albuterol and atropine, right, can cause a fast heart rate. I had told you that tachycardia is one of the first signs. It is the first sign of hypoxemia. When your patient's getting hypoxic, right? Stress and anxiety, before you take an exam in nursing school, right? Your heart rate's probably a little high. Trauma is from bleeding. You don't really need to know that. You'll learn that in med-surg too, actually. Pain, your patient's in pain, they may have a high heart rate. People that get infections, so they're septic, they can have a high heart rate, okay? Dehydration, they can have a high heart rate, okay? So those are important ones, okay? So that's sinus tach. Now, sinus tach, how we treat sinus tach, okay, is we figure out what is causing it, okay? So, and then we fix that, and then we fix sinus tach, okay? Atrial fibrillation is the most common clinically significant dysrhythmia. So you need to know it. And the other reason you need to know it is older adults, when they become stressed for whatever reason, there's like a lot of things that cause AFib. But for an older adult, they can get a cold and go into AFib. So like it's prevalent in older people. So you really need to know what it looks like, okay? Now, the heart rate's going to vary. If it could get very fast. So when it gets very fast, we worry that they're going to, have ischemia to their heart, okay? We worry they're going to have low perfusion, okay? So this is what you need to know. If you look at this rhythm strip, this rhythm here, print out this PowerPoint and put AFib side by normal sinus rhythm, you can see right away that this is irregular and it does not have any P waves. It's got these fib waves, okay? So, I wouldn't really memorize the characteristics. You do need to memorize the normal sinus rhythm, but I wouldn't really memorize this. I'm just going to show you a few things. They have the atria right here. There's no P waves, right? They're all squiggly lines, okay? These are called fibrillation waves. Now, this means that the atria are not contracting. When your atria contract, it contributes 20% of the blood to your cardiac output. So, people in AFib could develop low perfusion, okay? Signs and symptoms of low perfusion, okay? These are the causes, and you don't even need to memorize this, okay? I'm just going to tell you, for an older person, anything can trip them into AFib. Okay, now this is what's going on. Here's your normal heartbeat. Look how beautiful this rhythm is. This is what happens with AFib. Something trips somebody into AFib. It could be the dog snacks I talked about. It could be, an older person that gets, stressed because they, get pneumonia or something. They could go into AFib. But what happens is, instead of this nice, beautiful, the SA to the AV node, the atria are going rogue. They're shooting off all these impulses, and it gets very chaotic. Okay, so that's why we have this squiggly line. Now, why it's important for you to know, too, is that when the atria are not contracting, they're just kind of quivering, patients can get blood clots in here because the blood flow is not moving. Okay, so your signs and symptoms are going to be signs and symptoms of low perfusion. They could get confused, okay, because the brain is not getting enough blood. They could get short of breath, right? Because their lungs and their body is hypoxemic, okay? They're not getting enough oxygen. They could have palpitations. In fact, patients with AFib do sometimes complain about palpitations. That might be your first tip-off. Usually palpitations are like early beats, AFib, or it could be PVCs, premature ventricular contractions, okay? And that happens sometimes to people that are stressed. Okay, so the patient can have low blood pressure, right? They can get fatigued. They can get fatigued because anytime somebody is not getting enough oxygen, like when I talked about in the respiratory lecture, they're going to be like really tired, okay? Because, people that with anemia, they have low red blood cells. Red blood cells carry the oxygen. They get fatigued, okay? Pulse deficit. Now, pulse deficit means there's a difference between the apical pulse and the radial pulse. So you're going to check for that. So we listen to the apical pulse at the 5th intercostal line, mid-clavicular line. Okay, so remember that. That's where you find the point of maximal impulse too. And look for signs of poor perfusion, that confusion, thirst, the low blood pressure,
so you're
the
going to need to know
tachycardia.
Pulse deficit is really important. It takes 2 nurses to determine if somebody has a pulse deficit. One takes the apical pulse, which you need to know where to take an apical pulse. It's at the PMI, which is the point of maximal impulse. So it's at the 5th left intercostal space where it meets the mid-clavicular line. The other nurse will be taking the radial pulse, and the apical pulse will be higher than the radial pulse. The difference between the pulses is going to be called the pulse deficit. Okay, on this slide, I have a skeleton diagram that shows you where the PMI is. At the 5th intercostal space, mid-clavicular line, and remember it's on the left side. And then this next picture is 2 nurses assessing for a pulse deficit. So one checks the apical and one checks the radial pulse. And then they subtract the apical from the radial, and that will be your pulse deficit.
Okay, now, there's 3 things you have to remember with somebody with AFib. Now, sometimes you can convert the rhythm, but some people are going to live in chronic AFib, okay, because they've tried to convert them and they just won't stay converted, okay? So you got to control the heart rate. If the heart rate is high, they're going to need some medication. So we give those medications that slow the heart rate. So that's beta blockers, calcium channel blockers, or digoxin. We've got to prevent stroke. Remember, I told you the blood flow is not flowing as well as it should be. So they could develop what's called mural thrombi. So anyways, all that means is that they could develop a blood clot in their atrium, okay? And then when it starts beating normal again, they could develop a stroke or have a pulmonary embolism. So they need to get on some kind of anticoagulant, okay? Then convert the rhythm. So there are some medications that can control the rate and also convert the rhythm. So diltiazem is an IV calcium channel blocker, and there's some other ones too, okay? It's most important that you understand controlling the rate and preventing stroke. and converting the rhythm, but not necessarily know that, that they have to use these critical care drips. Okay, medications to treat fast atrial dysrhythmias. You can remember A, B, C, D. All right, adenosine, amiodarone, beta blockers, calcium channel blockers, and digoxin. And I have verapamil colored like this because one of the side effects is constipation, and ATI loves to test on this. So I remember VER for very, A for absent, and P for poo for constipation. Okay, that's how I remember that. All right, the electrical treatment for AFib, okay, if they're trying to convert somebody, it doesn't work, medications didn't work, is synchronized cardioversion. I'm not going to go into a lot of detail. I'm just going to tell you one little thing about cardioversion. I'm not going to go into any detail at all. But C is for circulation, so cardioversion is for people who still have a pulse. Okay, now VTAC, you have to remember this, and I'm going to give you some pointers. This is the QRS, okay? This is an upside down one, the one I showed you, and it's wide. Do you see how wide that is up there? Okay, now the other thing about VTAC is it's regular. Look at how regular that rhythm is, okay? All right, so it's regular, and that's important because it'll help you distinguish VTAC and VFib, which students sometimes have trouble with. Okay. VTAC, the treatment. If they're stable with a pulse, they're going to get medication. So the first thing you're going to do, your patient is in VTAC. Well, you're going to stay with your patient. You're going to check the LOC of vitals. You're going to call for help, okay? Because it's eventually going to end up in VFib, which we don't want. But if they're stable, they can be stable with a pulse. I've had people eating dinner in VTAC before, and I'm like sweating. But they can be stable for a while, okay? If they have a pulse but they're unstable, they're going to get cardioversion. If they have VTAC without a pulse, that means they're going to get defibrillation. D is for dead. And when somebody doesn't have a pulse, they're considered dead, okay? I don't mean to be blunt, but that's just an easy way to remember that people with pulses get cardioversion because they have circulation. And without a pulse, you get defibrillation. But there's only two rhythms that get defibrillation, okay? That's VTAC and VFib. Okay, so VFib. Now you see the difference? You can't really count this. It's not regular. See how it waxes and wanes here? Right? Because it's like, looks like high here and it's like getting low. So your priority is to defibrillate. Now this is, what's going to happen if you discover this on the monitor, right? You're going to check you're going to call out for help. You're going to do high quality CPR, but your priority is to defibrillate, okay? So somebody's going to be, somebody you're working with is going to be bringing the defibrillator. That's your priority. So if you get asked what the priority is, defibrillate, okay? Epinephrine and amiodarone are the drugs. You'll learn that in pharm. Okay, asystole is a flat line, but make sure it's really a flat line. So check the leads because sometimes when your patient sleeps, one could pop off, right? And it looks like a flat line. This is not shockable, okay? It's lethal. So you're going to do high quality CPR, epinephrine, and find out what's causing it.
Okay, this rhythm is called pulseless electrical activity. And so pulseless means the patient is pulseless. So essentially they're dead, right? But you have this beautiful looking rhythm. That's why it's called pulseless electrical activity. Okay? If you have a patient with this, you're going to do three things. You're going to push hard and fast, so that means you're going to give high quality CPR. You're going to give epinephrine IV because you know who epinephrine is used for, and you're going to assess for the cause because if you don't figure out what's causing pulseless electrical activity, the patient is going to die because that's the only thing that will fix this.
Okay. Yep. Asystole, high quality CPR, epinephrine, and find the cause. All right. Here are some tips for you. Every study session you do should be followed up with an assessment, which means NCLEX questions. So you're going to do some type of questions, okay? All right. You could do escape rooms if your instructor provides them, study books, a lot of things you can do, okay? Listen to the lectures over and over again. All right, that's it for dysrhythmias. Remember, you need to know the characteristics definitely of normal sinus rhythm, sinus brady, sinus tach. Okay, know how they're treated, right? Sinus brady. If they're fine, you're not going to do anything. If they're stable, you're not going to do anything. If they are unstable, they get atropine, and if that doesn't work, they get pacemaker. Tachycardia, fix whatever's, find out what's causing it and fix it. Okay. AFib, you need to control the rate and make sure they don't get blood clots. Okay, that's important. And they can also get cardioversion. VTAC, okay, you're going to assess the LOC and vital signs, and they may, if they don't have a pulse, they need defibrillation. Okay, the deadliest of all heart rhythms is VFib. Okay, so that's important. All right, so I'm more, concerned if somebody has VFib because that means they're dead. So VTAC and VFib are the only shockable rhythms. All right, that's it for dysrhythmias.